Welcome to the deep dive. We know you're looking to really get a handle on the brief symptom inventory, the BSI, and, well, do it efficiently.
Yeah, without getting lost in the weeds.
Exactly. So that's our goal today. Give you a clear, kind of structured understanding of this key psychological tool, but keep it straightforward.
Sounds good. And the BSI, it's essentially a brief, multi-symptom psychological screening instrument. Think of it as a quick check-in.
Quick check-in.
Yeah, a way to get an overview of a range of psychological symptoms someone might be experiencing. It usually takes maybe 10 minutes, and it asks about how you felt over the past week.
Okay, past 7 days. Got it. So we're focused on understanding what the BSI tells us. Are there, like, different versions for different people?
Yes, definitely. We're going to mostly talk about the version for psychiatric outpatients today, just as an example.
Okay.
But it's good to know there are also versions specifically for adolescents and others for people in psychiatric inpatient settings, as well as other outpatient groups, too.
Right, tailor it to the group.
Exactly. The core idea is the same, but the items, the questions, and how you interpret them might be slightly different.
That makes sense. You'd want it to be relevant. So for this outpatient version we're using as our example, who are the people that used to sort of set the baseline, the norms?
The norming sample. Good question. For the psychiatric outpatient form, they used data from 1,002 people. This was in a large eastern U.S. state.
Yeah.
The group was 425 men and 577 women, and demographically, let's see, about 32.6% identified as African American, 67.1% as European American, and then a tiny fraction, 0.3%, as other.
So that group gives us something to compare individual scores against.
Precisely. It provides that context.
Okay, now whenever we talk about psychological tools like this, reliability and validity always come up. Why are these so, well, crucial? What do they actually tell us about whether we can trust the results?
They're absolutely fundamental. Reliability basically tells us how consistent the BSI is. Is it dependable?
Like if I took it today and tomorrow.
Exactly. If your underlying feelings hadn't really shifted, you'd expect similar scores. The BSI actually shows pretty good internal consistency. That means the questions within each symptom area hang together well. The scores, called alpha coefficients, are between 0.71 and 0.85.
Okay, so the items are measuring the same kind of thing.
Right. And it also has decent retest reliability. Over a week, scores range from 0.68 to 0.90. That suggests scores are pretty stable short term, assuming your actual symptoms aren't, wildly changing day to day.
Okay, consistent. Got it. But then how do we know it's actually measuring what it says it's measuring?
Yeah.
That's validity, isn't it?
That's validity. Spot on. Does it measure, say, depression, or is it measuring something else?
Right.
And one key way we check that is by looking at how BSI scores correlate or match up with scores on other well-established psychological tests.
Like what?
Well, the data shows the BSI has moderate to good correlations with things like the MMPI and also the Wiggins and Tryon scales. Those correlations are in the 0.32 to 0.72 range.
Okay, so some overlap.
Yes, but what's really striking is the correlation with the SCL90R. That's another symptom checklist, a longer one.
Ah, I've heard of that one.
The correlation between the BSI and the SCL90R is super high, between 0.92 and 0.99.
Wow, that is high. Almost identical then.
Pretty much tells you they're tapping into very, very similar areas of psychological distress. It strongly suggests the BSI has good convergent validity. It measures similar things in a similar way to other respected tools.
Okay, that strong link is really important. So it seems like the BSI gives a consistent and reasonably accurate snapshot. Let's get into the meat of it then. What does it actually measure? I see there are 9 primary symptom dimensions.
Yes, these 9 dimensions are really the core of the BSI. They give you a profile across different symptom types. We can go through them.
Yeah, let's do that. What's first?
First up is somatization, SOM. This reflects distress that comes from perceiving issues with your own body, bodily dysfunction.
So like physical complaints, aches, pains.
Exactly, things that might not have a clear medical cause but are causing distress.
Okay, makes sense. Next.
Next is obsessive-compulsive disorder, OC. Now, this isn't necessarily a formal diagnosis from the BSI itself.
Right, it's a screening tool.
Correct. But this scale captures the extent you're experiencing obsessive thoughts. Those intrusive ones may be impulses or compulsive actions, repetitive things that are hard to stop and cause bother.
Got it. And then interpersonal sensitivity, IS. What's that about?
IS taps into feelings of inadequacy, maybe inferiority, and also discomfort in social interactions.
So feeling maybe self-conscious or easily hurt by others.
Yeah, that kind of thing. Feeling awkward, maybe taking criticism hard.
Okay. What about depression, PEP? That seems straightforward, but how does the BSI define it?
On the BSI, the DP scale primarily reflects feelings of hopelessness, sadness, lack of interest, maybe loss of pleasure in things you normally enjoy, core depressive symptoms.
Okay. And anxiety, ANX.
ANX covers nervousness, tension, worry, feeling keyed up.
Like restlessness, being on edge.
Exactly. Apprehension, maybe some physical signs of anxiety too.
Right. Then there's hostility, HOS. Sounds like anger.
It does relate to anger. HOS reflects tendencies towards aggression, irritability, maybe feelings of rage, resentment directed outwards.
Okay. Next on the list is phobic anxiety, PHOB. The description says it's similar to agoraphobia. Can you elaborate on that?
Sure, phobic anxiety here isn't typically about specific phobias like spiders or heights. It's more about that agoraphobic-like fear of feeling anxious in situations where escape might be difficult
Or embarrassing.
or embarrassing. Yeah, like being in crowds, public transport, places where you might feel trapped if you suddenly felt panicky or unwell.
I see. So it's situational anxiety of that type. Then paranoid ideation, PAR.
PRA focuses on suspiciousness, the feeling or thought that others might be trying to harm you, deceive you, or have negative intentions towards you.
Oh, okay. And the last one of the 9, psychoticism, PSY. That sounds maybe more severe.
It can tap into more severe experiences, yes. On the BSI, PSY reflects things like feeling withdrawn, isolated, maybe schizoid tendencies. And in some cases, it might pick up on experiences that are more removed from typical reality, like unusual thought patterns or even hallucinatory experiences.
Important to remember it's a screening tool, though.
Absolutely critical. An elevated PSY score would definitely signal the need for a much deeper, more comprehensive clinical evaluation. It's a flag, not a diagnosis.
Okay, that gives a really clear picture of those 9 areas. Thanks.
Mhm.
But the notes also mention global indices of distress.
Mhm.
What do these add to the picture?
Right, beyond the specific symptoms, the BSI gives 3 overall scores. Think of them as summary scores. The first is the Global Severity Index, GSI.
BSI.
And it's often considered the best single measure of overall psychological distress level. It factors in both how many symptoms you reported and how intense they were.
So higher GSI means more overall distress, generally speaking.
Generally, yes, it's a good overall intensity indicator. Then there's the Positive Symptom Distress Index,
PSDI.
PSDE. This one zooms in on the intensity only of the symptoms you actually said you experienced. It's the average distress level for the items you endorsed.
So if you only have a few symptoms, but they're really bothering you, the PSDI might be high.
Exactly. It tells you how intense the reported symptoms are. And the last one is the Positive Symptom Total, PST.
BST.
This is the simplest one, really. It's just a raw count of how many symptoms you endorsed, how many items you marked as causing you at least some distress. It tells you about the breadth of symptomatology.
Okay, so GSI is overall severity, PSDI is the intensity of reported symptoms, and PST is just the number of symptoms reported. That clarifies things.
You got it.
Now, we have this sample BSI profile here, an outpatient psychiatric male. Can we walk through that to see how this looks in practice?
Yeah, absolutely. Let's look at the raw scores first. These are the initial calculated scores before comparison to the norm group.
Okay.
So for this individual, SOM is 1.01, OC is 2.17, IS is 3.01, DEP is 2.51, ANX is 1.84. Oh, HOS is 61, quite high raw score there.
Hostility, okay.
Then PHOB is 2.61, PAR is 1.81, and PSY is 1.21. And the global raw scores, GSI is 1.73, PSDI is 2.31, and PST is 42.
42 symptoms endorsed. Okay. Those are the raw numbers. But then we have the T-scores. Why are these the ones we usually focus on?
Great question. The T-scores are key because they standardize these raw scores. They put them on a common scale based on that norming sample we talked about earlier.
The 1,002 outpatients.
Exactly. On the T-score scale, the average score for that norm group is set at 50 and the standard deviation is 10.
Okay.
So a T-score tells you immediately how this person's score compares to the average outpatient in that original sample. Above 50 is higher than average distress on that dimension. Below 50 is lower.
Right. Gives a context. So looking at the T-scores for this sample profile, let's say SON 58, OC 62, IS 56, DPPV4, ANX 49. HOS jumps up to 68.
Yep, still high after standardization.
Then PHOB 61, PR 59, PSY 53, and the global T-scores, GSI is 59, PSDI is 55, and PST is 61.
Mm-hmm.
So comparing those to the average of 50, which ones really stand out as elevated here?
Well, Hostility, HOS, at 68 is definitely noteworthy. That's almost 2 standard deviations above the mean for that norm group, suggesting significantly more hostility reported than average.
Okay.
Obsessive-compulsive OC at 62 and phobic anxiety, PHOB, at 61 are also clearly elevated, more than 1 standard deviation above the mean.
And the PST.
The positive symptom total, PST at 61, is also elevated, meaning this individual endorsed more symptoms overall than the average person in the norm group. The GSI at 59 is also somewhat elevated, approaching that clinically significant range. Anxiety at 49 is basically average.
Okay, so HOS, OC, PHOB, and PST are the main flags here.
Yeah.
That makes interpreting it much clearer. Now, what about this idea of caseness? What does that mean?
Caseness is a term sometimes used with screening tools like this. It refers to using specific score cutoff to identify individuals who are, statistically speaking, likely to meet criteria for needing psychological services. It's a kind of threshold.
A threshold for potential clinical significance.
Sort of, yes. Based on the info here, the suggested criteria for potential caseness using the BSI are a GSI T-score of 63 or higher,
Okay, 63.
and/or a PSDI T-score of 63 or higher, and/or a PST T-score of 63 or higher. If someone meets or exceeds any of those thresholds, they might be considered a potential case needing further evaluation.
So let's apply that to our sample profile. His GSI T-score was 59.
Right, below 63.
His PSDI was 55.
Also below 63.
And his PST was 61.
Still below 63.
So even though some of his individual scores, like hostility, were quite elevated, based purely on these specific global index cutoffs for caseness, this particular individual wouldn't meet that threshold.
That's correct, according to these criteria. It highlights that someone can have significant distress in specific areas without necessarily crossing the overall severity thresholds used for this definition of caseness.
But it doesn't mean they wouldn't benefit from help, right?
Absolutely not. These are just statistical guidelines. Clinical judgment is paramount. Elevated scores like his HOS, OC, and PHOB clearly indicate areas of significant distress that warrant clinical attention, regardless of whether the global scores hit that specific 63 mark.
That's a really crucial distinction. These tools guide, they don't dictate.
Precisely.
Now, there was also a mention of a specific profile, sometimes seen on the SCL90R, the one related to substance abuse, with high DEP, OCIS, ANX, and maybe HOS.
Yes, that pattern has been noted in some SCL90R research.
Given how closely you said the BSI and SCL90R are related, is it reasonable to think we might see similar patterns on the DSI for individuals with substance use issues? Like, could that combination of elevations be a clue?
It's certainly plausible, given the strong overlap. If you see someone scoring high on the BSI on, say, depression, obsessive-compulsive, interpersonal sensitivity, and anxiety, maybe also hostility, it could raise a flag about potential co-occurring substance use.
Not definite, but a possibility to explore.
Exactly. It's not a diagnosis, but that kind of pattern might prompt a clinician to ask more specific questions about substance use during a fuller assessment. It shows how looking at the pattern of scores, not just individual highs or lows, can be informative.
So it's about looking for those clusters, those combinations of symptoms.
Yes. The BSI gives that broad overview, and patterns within it can generate hypotheses to explore further. You need the clinical interview, maybe other tests, to really understand what's going on.
This has been incredibly helpful, a really thorough look at the BSI. So wrapping up, it's a short, dependable, and reasonably accurate tool.
Valid,
A
yeah.
valid tool for getting a quick read on a bunch of psychological symptoms, those 9 dimensions, plus those 3 overall distress scores.
That's the essence of it. And hopefully listeners now feel they have a much better grasp of how it works, what the scores mean, how they relate to norms, and that concept of caseness. It should provide a really solid foundation.
Definitely. It's quite powerful how much information you can get from something relatively brief. It really makes you think, though. Given these different dimensions and the idea of setting cutoffs for caseness, what are some of the challenges or maybe ethical points to consider when using quick screening tools like the BSI out there in the real world? Something perhaps for our listeners to mull over that balance between efficiency and the sheer complexity of people's individual lives. Thanks again for this deep dive.